Ready? 30 seconds or 30 minutes or no? Yes, certainly I'll start. Yes, we can start. Good evening, everyone. And I'm Dr. Srinivas Chakravarthy from Apollo Health City in Hyderabad and from Shubha Comprehensive Cancer Care also in Hyderabad. And I'm a medical oncologist and hematologist. And today we are going to talk about primary CNS lymphoma. And I hope all of you can see me and see the presentation and hear me well. Unfortunately, I cannot see you nor can I hear you right now. I can only read what you write, that too all after a refresh period about 20 seconds or so. Um, I know there's a question answer session after the presentation, but I typically like to keep this interactive just to prevent us all from going to sleep and also from trying to get it over with fast so that it will be hopefully painless for both of us. So please feel free to write your questions, comments in between as well. Please identify yourself, your name, your institution, and type the question, and hopefully we'll be able to move this along fairly pleasantly. So shall we begin? Yes? So the topic for the day is primary CNS lymphoma. And let's start with a case and walk through with what happened with this real life case. We had a 58-year-old businessman not too long ago who has controlled diabetes mellitus with no other comorbid conditions. And he presented with sudden onset of right focal seizures to an emergency room. And he was admitted and further workup was done. Now, what do you think should be done next? Obviously, a neurologist did evaluate him, and the first thing that a neurologist will get is a MRI of the brain. And so here is the MRI of the brain that was done, and this is a T1 weighted image, contrast gadolinium enhanced image. And you can very clearly see the abnormal lesion here. Any comments on this? Those of you who are familiar with MRIs and workups? Now, here what we see is a supratentorial lesion, and PCNSLs are the vast majority are supratentorial. It is solitary, it is infiltrative, if you can see. It's not well circumcised, the borders are very infiltrative into surrounding brain parenchyma. Typically, it happens in the periventricular white matter, and there is typically subependymal extension, and sometimes it can go under the corpus and cross over into the other brain as well. And they're typically T1 hypointense and enhanced pretty vividly on gadolinium, as you can see here. And it's generally a homogeneous enhancement with very little areas of necrosis. Now, this is what characterizes it from other differential diagnoses like glioblastoma multiforme, which is a leading differential in this situation. So here, at presentation, we have several clues to the diagnosis. First of all, 50, a patient in his 50s, where we have the highest incidence of PCNSL. There's a male preponderance for some unknown reason. And in a large retrospective series, when people presented with rapidly progressive neurological symptoms such as sudden onset of seizures or rapidly progressive paresis or cognitive dysfunction, and they were seen to have a brain mass, the vast majority of them on biopsy turned out to be PCNSL. So this seems to be a characteristic presentation of PCNSL, rapidly progressive neurological symptoms in a middle-aged male. Now, the MRI findings are also quite typical for a PCNSL. So, we strongly suspect a PCNSL just from this presentation and from this MRI. And what is the next step? The neurosurgeon, of course, will want to do a biopsy. So, the neurosurgeon did evaluate this case and he attempted a partial excision. In other words, he tried to attempt maximal resection of the lesion. Now, do you have any comments on this? I'd like to hear your comments upon this and if there's anything else that you want to suggest. Please type your answers or comments, and in 20 seconds, we can review them. I'm going to refresh and see if we have any comments uploaded yet. I don't see any comments, any questions, any opinions. Does anyone have any opinion on this at all? A middle-aged male with sudden onset of seizures who has an infiltrative periventricular isolated lesion that is highly suggestive clinically of primary CNS lymphoma. Just a radiological and clinical diagnosis so far. Are there any comments, questions, or concerns on the fact that the neurosurgeon attempted maximal possible excision of this lesion? So I don't see any answers here or any questions here, not one. So either there are no concerns with this, or maybe there's a technological issue. So shall I just continue? Now, in a case like this, where we suspect primary CNS lymphoma, what we ideally prefer is a stereotactic biopsy, needle biopsy. So the least invasive method of obtaining a biopsy is what is highly preferred and what is highly recommended. We do not want to cause any unnecessary problems at all, because for the last 2.5, 3 decades, we have an abundant amount of data that suggests that maximal excision of a primary CNS lymphoma does not result in improved overall survival. On the other hand, it may leave a large deficit and may cause problems in the future. So we just need a biopsy, and further action can be taken based upon the biopsy. If possible, the neurosurgeon should be encouraged to do a simultaneous CSF analysis, a complete CSF analysis, along with cytology and flow cytometry. Sometimes we consider doing T-cell gene rearrangement tests as well. However, a minimum is cytology and a flow cytometry along with a usual routine CSF analysis. Now, this is what we highly prefer. And this has been the standard teaching for the last 2 to 3 decades. However, recently, there has been the GPSG, the German primary lymphoma, CNS lymphoma group 1 trial, which is a phase 3 randomized controlled trial, quite large, more than 500 patients, which essentially looked at the question of chemo alone versus chemotherapy plus whole brain radiation. So the question they asked on this randomized trial is quite different. However, on this trial, when they did a retrospective analysis of that subset of patients who actually did undergo aggressive resection for one reason or the other, they actually found that in this subset of patients, they had an improved progression-free survival as compared to those who just had a stereotactic biopsy. So this finding actually challenges the traditional view that maximal resection is not beneficial in primary CNS lymphoma. However, let us understand that this is a retrospective subset analysis of a randomized controlled trial for some other reason. And let us also understand that this shows improvement in PFS, but we still don't have any data on the overall survival. So at this point in time, this has to be still considered a research question. The standard recommendation of the least invasive biopsy technique possible still stands. That does not change. However, given this finding, It may not be a bad idea to attempt maximal resection under certain specific circumstances, such as when it is a peripheral tumor, it is very well circumscribed, and you have a large tumor with a lot of mass effect or potential herniation, where you want to do rapid debulking. So maximal resection under those circumstances may be encouraged and may even be beneficial, but please understand this is only under these specific circumstances. For the vast majority, the standard party line is that stereotactic biopsy or other least invasive method is what is preferable. All right. So we have the biopsy results on our patient, and the biopsy results came out to be B cell diffuse large cell non-Hodgkin lymphoma. This is what it turned out. And this is typically what we see in primary CNS lymphoma. The vast majority of lesions are B cell, and the vast majority of lesions are diffuse large cell morphology. About 5% or so are T cell, which generally tend to be low grade and more indolent, and very rarely we get rare entities such as meningeal malt, which may mimic a meningioma, in fact, and a variety of other rare histopathologies. Now, typically, these lesions, as we discussed in the radiology, are infiltrative. And as you can see in diagram A, the tumor on the right side infiltrates below the corpus callosum and has gone across over to the contralateral side. So this is the reason why primary CNS lymphomas are considered whole brain disease. By definition, we do not consider them as localized disease, we consider them as whole brain disease because they tend to be so infiltrative. And they exhibit angiotropism, which you can see very clearly in slide B. These lymphoma cells, in slide B, you have an effacement of the normal architecture by this monotonous, mature B lymphocytes, just as it happens in any other non-Hodgkin lymphoma. In addition, you see that the lymphoma cells infiltrate around the capillaries, around the arterioles, and they sort of infiltrate through the capillary wall, and that may be a big reason why they disrupt the blood-brain barrier. And 95% or more are CD20 positive, and many of them are BCL2 positive. Many are germinal B cell type. However, there's a much higher proportion of activated B cell types among PCNS lymphomas rather than peripheral non-Hodgkin lymphomas. And as you know, that portends a poorer prognosis. Now, there are several, typically we do not send these lesions off for cytogenetics or for molecular rearrangements. However, chromosome 6 short arm 21 losses are quite common. They tend to be recurrent in primary CNS lymphomas. So we have our biopsy report, and we have diagnosed it definitely to be a B cell diffuse large cell non-Hodgkin lymphoma, probably primary CNS lymphoma. What do we do next? What we do in any other malignancy, we stage them. Now, how do we stage them? Please increase the volume, not audible. Is this audible now? Do you get any feedback live from the place, from some place? Is anybody giving you a live feedback? No, not only asking questions about how the audio is, how the video is. But there are some 3 comments that the audio is not audible. The rest is all good. Okay, shall we go on? So Dr. Siddhartha Nanda says PET CT. Yes, certainly PET CT should be considered. Anything else? Anybody else? Okay, all staging tests in any malignancy need to be done on a logical basis. Where obviously, there are recommendations, there are guidelines, and most of us follow the guidelines as they stand. However, there needs to be the reason, rhyme, and a logic, scientific logic before how we state. So we ask a series of questions in primary CNS lymphoma. The first question we ask is, we're calling this primary CNS lymphoma, but is it really primary or is it secondary? Now, if you take 100 diagnosed cases of CNS lymphomas, about 4 to 12% of them end up being secondary. In other words, the lymphoma started elsewhere in the body and you have CNS involvement. Typically, that tends to be leptomeningeal involvement, but quite sometimes it can be parenchymal involvement as well. So, because a substantial proportion of brain lymphomas tend to be secondary and not primary, we need to make sure that it is truly a primary CNS lymphoma, because obviously secondary CNS lymphomas have a different treatment paradigm. So yes, certainly a whole body PET-CT scan should definitely be considered, as in any other staging of lymphoma. If you are unable to do that, a contrast enhanced CT of the whole body is also acceptable. Another important thing is a testicular exam should be done in every male. A physical examination should include the testicular exam because it's a very common sanctuary site. And if the male is above 60, you may also strongly consider doing a testicular ultrasound even if the exam is normal. However, if you've done a PET-CT scan and that shows normal testes, you don't need to do an ultrasound. The second question we ask is there leptomeningeal involvement? Now, why is this important? This is important because up to 40% of primary CNS lymphomas can have leptomeningeal involvement. Now, typically, the treatment is the same. We will talk about high-dose methotrexate a little later. But in the modern high-dose methotrexate protocols, we do not need to treat the leptomeningeal compartment separately. However, having said that, if we are not using adequate doses of methotrexate, or if the leptomeningeal compartment is the CSF is positive in spite of high dose methotrexate, they do require intrathecal methotrexate. Sometimes they may require focal radiation to spinal mets, the spinal leptomeningeal mets. For this reason, it is important to know whether there is leptomeningeal involvement as well. So we have to do a proper, complete, thorough CSF analysis, ideally together with the brain biopsy. If not possible, then after adequate healing from the brain surgery. And the CSF analysis should always involve cytology and flow cytometry. In specific cases, you might consider T-cell gene rearrangement studies. Now, if the CSF is positive, then we need also to get an MRI scan with contrast of the spine. The third question is there eye involvement? Now, eye involvement also happens in about 15 to 25% of primary CNS lymphoma. Vice versa, people who present with uveitis, malignant uveitis, almost 80% of them will eventually progress on to get CNS lymphoma. So it works both ways. People who have primary CNS lymphoma may end up having ocular involvement, or people with isolated ocular involvement may eventually progress to get CNS lymphoma in a substantial majority of cases. So in either case, checking for eye involvement is very important. And in the eye, typically you get a malignant uveitis. You can have involvement of the retina, you can have an involvement of the choroid, or you can have involvement of the vitreous. And the classic test we do is a retinal slit lamp exam. The reason for this is if there is ocular involvement, high-dose methotrexate alone may not be sufficient. If high-dose methotrexate alone does not eradicate the ocular disease, they may require additional radiation to the eye. So for this reason, it is important to know if there is ocular involvement as well. So a PET-CT scan of the whole body or a CT scan of the whole body, testicular exam in all males, and consider an ultrasound if necessary, especially in males older than 60 who have suspicious PET-CT scan. And we have to analyze the CSF, and if that's positive, get an MRI of the spine, and always have a slit lamp examination of the eye. The final very important question is, what is the immunodeficiency status? This question is extremely important. because a substantial number of people, especially in the developing world, turn out to be HIV positive. So HIV status is extremely important. Now, immunodeficiency associated CNS lymphomas is now considered a separate category under the WHO 2016 um, classification. And the reason for that is not just HIV, but also people who have congenital immunodeficiency syndromes such as Wiskott-Aldrich, or people who are on immunosuppressant therapy for rheumatoid arthritis, SLE, or whatever, or people who have received heavy-duty chemotherapy in the recent past, people who have undergone transplantation. All these are at high risk of getting lymphoma, as you know. And among those lymphomas, primary CNS lymphoma is also a category. And the pathogenesis of primary CNS lymphoma in the immunodeficient individuals seems to be different. And the vast majority of them are Epstein-Barr virus associated. You can identify the EBV capsid in these lymphomas in the vast majority of them, whereas in immunocompetent primary CNS lymphoma generally are not EBV associated. Now, remember that PCNSL is an AIDS defining illness, and generally they tend to be multifocal. They tend to have more of a mass effect, more of edema, and they generally have a much poorer prognosis than immunocompetent um, um, primary CNS lymphomas. However, in the modern era of highly active antiretroviral therapy, prognosis seems to be improving well for these patients as well, and there is no reason to treat them any differently from other primary CNS lymphoma cases, provided they are on highly active antiretroviral therapy, compliant with their therapy, and they're otherwise doing well. So what do we do after we stage? So one of the questions in staging was, so we have some answers for the staging. PET-CT was suggested, we discussed that. Um, Prityananda Mishra cannot hear. That's taken care of? Okay, fine. So um, bone marrow exam was what has been suggested by Dr. Siddharthananda and by Dr. Naveen. Certainly, bone marrow biopsy aspiration, I did not mention it here. Bone marrow biopsy and aspiration are these days not routinely done for primary CNS lymphoma unless there is a clinical indication. So it is a category 2B recommendation. So ideally, when you have suspicion for bone marrow involvement, such as an abnormal CBP, or when you have a very high LDH or extraneural disease elsewhere, is when you have to do a bone marrow biopsy. But otherwise, in a otherwise straightforward, well-staged primary CNS lymphoma, doing a routine bone marrow examination and aspiration is a category 2B recommendation. So what do we do after we stage? We score things, right? We're medical oncologists, most of us, and we love to score things. We live on scores, like all other lymphomas we score. Now, primary CNS lymphoma has its own scoring systems. One of the oldest and time-honored ones is the International Extranodal Lymphoma Study Group score, otherwise called the IELSG score, because it's time-honored and we've been doing it for a long time. That is actually the commonest score that is in use. However, there are other models, as you can read on your screen, the Nottingham, the Memorial Sloan Kettering score, and the new AMC model, and so on and so forth. The Memorial Sloan Kettering score is the other popular one for a good reason. It's very simple. There are only two parameters you look at: the age and the performance status. And the simplicity and the clinical decision making in MS cases is what makes it popular. The IELSG looks at five parameters: age, performance status, LDH, protein level in the CSF, and whether the lesions are deep. Now, there is no solid proof that any of these scores really predict the outcomes, um, especially in this modern era of the newer chemotherapy, the newer chemotherapy, newer regimens, modalities. However, the ILHG score, for example, Based on the score, you divide them into low, moderate, and high risk. And the 2-year overall survival in those patients who are treated with high dose methotrexate, those who have a low score have a 2-year survival probability of 85%, moderate is 57%, and high risk have only about 24% probability of survival at 2 years. Any questions or issues on the scoring? Dr. Sumit asks any role of doing samic or double hit or double expressor status during diagnosis. Not for primary CNS lymphoma. Primary CNS lymphoma is quite rare around the world, although the incidence is increasing at this point in time. In primary CNS lymphoma, in general, they have activated B cell type, and in general, they are MYC positive, and in general, they have a poorer prognosis than systemic non-Hodgkin lymphoma. And routinely doing double hit status is not suggested in primary CNS lymphomas. So once you do the prognostic scoring, we go to treatment. As of today, the standard of care in terms of treating a primary CNS lymphoma is chemotherapy. Although you do have other options, which we'll discuss in a short while, the standard of care is chemotherapy. And in chemotherapy, again, the standard of care is high dose methotrexate based induction. Now, my question to the audience, when we say high dose methotrexate, what exactly is high dose? Does anyone have any ideas? The efficacy of high-dose methotrexate has been established way back in the 1970s itself by Dr. Canellos from the US, and by 1990s it had become the standard of care. Um, and we do know that high-dose methotrexate penetrates well into the CSF, well into the brain. It is highly active in primary CNS lymphoma. Primary CNS lymphomas seem to be twice as responsive to methotrexate as peripherally occurring non-Hodgkin lymphomas. So there is something different about the biology of primary CNS lymphoma that makes them much more susceptible to methotrexate than the usual lymphomas that we face. So for all these reasons, high-dose methotrexate has become the incontroversial standard of care as far as induction chemotherapy is concerned for PCNSL. But what exactly is high dose? Anyone has any comments? You can read off the screen. You can cheat if you like. In the meantime, we have a question from Dr. Meenakshi. What is considered a depletion? Something that is periventricular, something that involves the thalamus, the hypothalamus, the basal ganglia, or the periventricular white matter. Any comments on what exactly is high-dose methotrexate? So for all the above mentioned issues, high-dose methotrexate has become the standard of care, as we said. However, as of date, we have still not figured out what is the ideal dose that is meant when we say it's a high-dose methotrexate. So we'll have to go according to the specific protocol that we choose to use. However, there are a few things we have learned over the years. The first thing I'd like to bring to your attention is that treatment should start as soon as possible from the time of diagnosis. As soon as the wound is healed, as soon as the diagnosis is established, as soon as the performance status improves with steroids or some other modality, we have to start the diagnosis. There is evidence that a delay of diagnosis by more than 30, a delay of treatment more than 30 days after the diagnosis significantly impacts overall survival. So that's the first thing. Second thing is high dose methotrexate, the doses of methotrexate of more than 1 gram per meter square are required to achieve adequate parenchymal concentrations. And a dose of more than 3 grams per meter square given every 2 weeks for about 6 weeks, there is proof by Dr. Khan and all that you can potentially avoid intrathecal methotrexate, and these doses of methotrexate at the minimum achieve higher CSF and parenchymal concentrations than intrathecal methotrexate actually does. So in typically somebody is getting more than 3 grams, 3.5 grams of methotrexate per meter square every 2 to 3 weeks for a minimum of 6 cycles. They do not even require intrathecal methotrexate per se. So when we talk of high-dose methotrexate as a standard for primary CNS lymphoma, we typically like to see doses in excess of 3 grams per meter square. And most of the protocols will use either a dose of 3.5 grams per meter square or 8 grams per meter square. This has become the most common doses in use today, depending upon the protocol. The other thing we have learned is that typically a minimum of 4 cycles of induction of high-dose methotrexate, especially if it is being used alone, is necessary before you consolidate to achieve a significant long-term remission. So these are the paradigms that we need to keep in mind when we choose a protocol, appropriate protocol for treatment of primary CNS lymphoma. Now, since the millennium, since around 2000, the use of non-cross resistant drugs has also become the standard of care, and the logic is quite simple. We have newer, safe, effective chemotherapy which can achieve adequate levels in the CNS and which have a mechanism of action other than high-dose methotrexate. So just as in the case of any other lymphoma, combination therapy with methotrexate and some other drug that is non-cross resistant and non-overlapping toxicity can provide much better outcomes. And Dr. De Angelis in the early 2000s and then Dr. Ferreri have established the role of combination chemotherapy inductions. Now, these non-cross resistant drugs, the typical examples are high-dose cytarabine, otherwise called high-dose AC, HDAC, carmastine, etoposide, temozolomide, thiotepa, vincristine. All these are used in standard protocols nowadays as a non-cross resistant partner to high-dose methotrexate. Now, depending upon the protocol and depending upon the clinical situation of the patient, you can use these non-cross resistant drugs in combination with high-dose methotrexate as part of induction, or you can induce with high-dose methotrexate alone and then use these drugs as part of consolidation. So you have a choice of doing either one. What about immunotherapy? What is the role of rituximab? Do you know? Does anybody have any ideas on this? So while you ponder that question, Dr. Siddharthananda has commented that high dose is methotrexate more than 2.5 grams per meter square, Dr. Meenakshi more than 500 milligrams per meter square, and Dr. Venkat Pradeep Babu more than 500 milligrams per meter square. I think we have already discussed this, so I'm sure this question has been answered. The minimum is 3.5 grams per meter square is the dose of methotrexate. That is the minimum effective dose in an immunocompetent average host, because that is the dose that has been proven to achieve a sufficiently high level of methotrexate in the CNS parenchyma and in the CSF that potentially we can avoid giving intrathecal methotrexate even. And the most common doses used are 3.5 grams per meter square or 8 grams per meter square. Any ideas on immunotherapy? So immunotherapy, so yes, Dr. Meenakshi talks about the matrix regimen and Dr. Ravikiran talks about the MTR regimen, perfectly fine. Two reasonably common good regimens to be used in primary CNS lymphoma. As far as immunotherapy is concerned, which effectively means rituximab, it's an interesting topic in primary CNS lymphoma. There is no proof that rituximab, there's no absolute proof that rituximab significantly improves any outcome in primary CNS lymphoma as of date. Now, typically, rituximab given in the normal doses, routinely, systemically, achieves less than 1% CSF penetration. It's a large molecule. It doesn't cross the blood-brain barrier typically. However, there's a lot of anecdotal experience in primary CNS lymphoma. There are retrospective studies, and we see that in salvage situations of primary CNS lymphoma, that rituximab does produce significant response rates in primary CNS lymphoma as well. And why does that happen? That probably happens because the majority of are CD20 positive anyway, and rituximab probably crosses a disrupted blood-brain barrier, as we discussed. The blood-brain barrier is not normal in primary CNS lymphoma. Because of the angiotropism and because of other mechanisms, the blood-brain barrier is disrupted in primary CNS lymphoma, which probably facilitates the transfer of rituximab. So response rates are well known and well described with rituximab combinations in primary CNS lymphoma as well. As far as solid data is concerned, some of the randomized data that has been studied, such as the HOVON 105 trial, which is a phase 3 randomized controlled trial with almost 200 patients, which looks at the role of rituximab, chemotherapy plus or minus rituximab, did not show a difference in response rates or in progression-free survival. Having said that, these trials are small, they're limited, they may not be able to show a significant survival advantage. In addition, they have internal design flaws. For example, this HOVON trial, they effectively gave only 2 cycles for most of the patients, and that may be an inadequate dose both of the chemotherapy as well as of the rituximab. The other issue being rituximab, as we know in other situations, rituximab may partner better with certain backbones of chemotherapy rather with other chemotherapies. Now, last year, a fairly large meta-analysis was published looking at 2 randomized controlled trials and 6 retrospective studies of the role of rituximab in primary CNS lymphoma. And this meta-analysis did show a significantly improved 5-year progression-free survival as well as a 5-year overall survival advantage with a fairly significant p-values. So based on the fact that the meta-analysis show benefit, based on the fact that rituximab is quite a safe drug to give, and based on the fact that it may in fact cross the disrupted blood-brain barrier in primary CNS lymphoma, and that these days even cost is not such a big issue, the cost having come down thanks to generics and the price control measures, rituximab has become quite popular in the along with chemotherapy in the treatment of primary CNS lymphoma, with the understanding that as of yet we do not have high quality evidence to show benefit in PCNSL yet. Phase 3 trials are going on, so we'll wait and see for more information upon that. Any other comments on this? Dr. Sumit suggests we can use intrathecal rituximab. Yes, it has been tried. Intraocular rituximab also has been tried for ocular lymphomas. However, that is entirely anecdotal, and in the vast majority of patients is not needed. As we discussed before, even if there is leptomeningeal involvement and even if there is ocular involvement with lymphoma, high dose methotrexate in excess of 3.5 grams per meter square typically penetrates well both into the eye as well as into the CSF, such that we do not need to give such that we sterilize both spaces, and we typically do not need to give any additional therapy into the compartments. Having said that, at the time of restaging, we do routinely have to check the CSF again and the eye again to make sure that they're sterilized. The penetrance of high-dose methotrexate is better into the CSF compared to the vitreous. So sometimes the eye may not be completely sterilized if it is involved to begin with. So you might require intraocular methotrexate is typically what is given. Intravitreous rituximab also has been given along with it. And the same thing goes for CSF as well. If the CSF is not sterilized by high-dose systemic methotrexate alone, then you will have to give intrathecal methotrexate, and you can consider intrathecal rituximab, although you have to understand that is anecdotal. There is no systematic evidence to show that intrathecal rituximab, in addition to standard intrathecal methotrexate, actually improves any outcome. So in our case, he turned out to have an IELSG score of 2, which is moderate risk. And as Dr. Meenakshi suggested, we went by what Dr. Meenakshi would have suggested. We have started him on chemoimmunotherapy as on the matrix regimen. For those of you who are not familiar, the matrix regimen, M is methotrexate, A is Aracy, that is high-dose cytarabine, T is thiotepan, sorry, and Rix is the rituximab. So what is the data on MAT? This is one of the induction regimens that we can use, as you're well aware, and as you already commented, MTR is another regimen. The Angeles is another very popular regimen. The Ferrari regimen, which just uses high-dose methotrexate along with high-dose cytarabine upfront in induction, is also very, very popular. More recently, there is good phase 1 data supporting the use of high-dose methotrexate with temozolomide and rituximab. Or another regimen called RMPV, that's rituximab, methotrexate, procarbazine, and vincristine. Fairly well tolerated, low side effects, and seems to be effective. All these are acceptable regimens. What is the data supporting the matrix regimen, which created some ripples a couple of years ago? This is based on the IELSG 32 trial, which is a phase 2 randomized control trials, more than 200 patients, which for primary CNS lymphoma, you understand that 200, 300, 500 are quite big numbers actually. Typically, we have between 30, 100, 200 patients on most of the trials that we see in primary CNS lymphoma. This is a reasonably big trial, although it's a phase 2 trial. It's still a randomized control trial from 5 European countries. This is meant for patients less than 70 years. This is not meant for the elderly. So there was a two-step randomization on this trial. The first randomization, which looked at induction therapy, arm A was high-dose methotrexate plus high-dose cytarabine, which is a standard arm. And the comparator arms were arm B, which looked at high-dose methotrexate, Aracy, and rituximab, and arm C, which looked at high-dose methotrexate, high-dose Aracy, plus thiotepa, plus rituximab. So either two standard chemotherapies plus rituximab, or 3 chemotherapies plus rituximab. This was a 3-arm randomization. As you can see, the complete response rates are reported. The addition of rituximab to the standard chemotherapy backbone increased response rates barely significantly. The three-arm study, 3 chemotherapies plus rituximab, gave us a significantly improved response rates over the standard 2-drug regimen, or even the standard 2-drug regimen with rituximab alone. So there are dramatically improved complete response rates with the matrix regimen, with the high-dose methotrexate, high-dose Aracy, and high-dose and the thiotepa, along with the rituximab regimens. However, this comes at a cost. There is a 6% toxic death rate, and the majority of toxicity is hematological and acute. There seems to be very little long-term toxicity, and this has to be very clearly kept in mind, that there's a price to be paid in toxicity. And also, we do not have data yet on overall survival. That data is pending yet. However, we chose to treat this gentleman on the matrix regimen, and this is what happened. He tolerated the first cycle fairly well, but after the second cycle, he went into neutropenic septic shock, had to spend several days in the ICU, but he pulled through eventually and recovered sufficiently that we were able to give him cycle 3 as well, after which he ended up with aspergillus pneumonia, which also we started treating. After this, we decided not to give him any more induction chemotherapy, and he was restaged with an MRI of the brain, which showed complete response in the brain after 3 cycles of the induction with matrix. Now, On the IELSG 32, the planned number of cycles for induction was 4. So we were able to achieve 3 cycles out of 4. And he did, and the patient did achieve a complete response. Now, what do we do? Any comments? What do you propose we do with this patient? How do we go forward? Patient was willing to push ahead as aggressively as possible, but his wife was completely fed up. She clearly and categorically said, I'm not going to take care of him anymore if he falls sick again, and I'm scared to death that something will happen. He had a near death experience 2 times with neutropenic septic shock and then with aspergillus pneumonia. No more therapy, no more chemotherapy, zilch. That's what she said. Patient, on the other hand, said, what the heck, I made it to 3, made it to 2. I'll make it through the third one. Please go ahead with any further therapy if that is what is recommended. So what would you recommend? We always face social situations, we always face logistic situations. Most of us as oncologists have to deal with the logistic situations and the family affairs more than we deal with medical affairs. And it's very important for us to take those things into consideration as well, apart from the data, apart from whatever published data we have, and apart from whatever clinical experience we might have. It is always important to take the input of the patient and of their family and of the logistic situation and the family situation before we proceed further. So do you have any recommendations under these circumstances? Dr. Meenakshi is familiar with the matrix regimen, so does she have any suggestions for us? We have an interesting question from Dr. Ravi Kiran. Where no facility exists for high-dose methotrexate, and methotrexate levels, serum methotrexate levels, can one use CHOP? Yes, one can. CHOP or CHOP-R is known to be effective in primary CNS lymphoma. However, it is not the ideal regimen. With standard dose CHOP, the CSF, the parent brain penetrance, CNS penetrance is quite low. So if you're going to use CHOP, you can potentially use CHEOP, CHEOP, that means CHOP with the addition of etoposide. That is something you can do. If you want to avoid, if you do not have serum methotrexate level available, you can use high dose cytarabine with rituximab. You can also use a combination of rituximab and temozolomide, which is becoming very popular now, especially among the elderly. So you do have regimens which you can use where you do not have to check methotrexate levels. Yes. But CHOP is not just standard plain vanilla CHOP is not the ideal regimen to use. So let us look at the data before we tackle these patients. So Dr. Nanda suggests radiation, and Dr. Ravikiran also suggests radiation consultation. So that's great. That's certainly something on the table that we would be discussing. But before we talk about that, let's just look at the data of the IELSG 32 real quickly. As we said, the IELSG 32 is a randomized phase 2 trial which has established matrix regimen as a standard. And as we discussed, it had 2 randomizations. The randomization for the induction arm showed the efficacy of matrix regimen, especially in terms of the complete response rate. Now, the second randomization on the same trial was for consolidation. So those who achieved a response to matrix were randomized to receive either whole brain radiation consolidation, as Dr. Nanda and Dr. Ravi Kiran recommended, versus autologous peripheral blood stem cell transplantation. So high dose chemotherapy with autologous PBSCT was the other arm of the randomization. Now, I'm sure you realize that as far as consolidation of primary CNS lymphoma is concerned, radiation has been a part of the older regimes. because if you recall, those of you who will recall, at once upon a time, radiation alone used to be the standard of care way before chemotherapy made its entrance. The CNS penetrant chemotherapies made their entrance in the 70s, 80s, and 90s. So the earlier protocols did you continue to use radiation as part of um, consolidation after high dose methotrexate. More recently, among hematologists, autologous peripheral blood stem transplantations have become much more popular as consolidation because of a fair amount of phase 1, phase 2 data that suggests significantly improved progression-free survivals. Some data even suggests overall survival progression. There is no good phase 3 data yet addressing this issue, but since we do have data suggesting improvement in PFS, if not in OS, and because autologous peripheral blood stem cell transplantations have become much more common now, much more easier with modern supportive therapy, that has become very popular rather than radiation, brain radiation in terms of consolidation. Now, ILSG32 actually looks in the second randomization between uh, consolidation with whole brain radiation therapy versus consolidation with autologous peripheral blood stem cell transplantation. And what it shows is that there is really no difference, significant difference between the 2-year progression-free survival states. As of yet, we do not have the overall survival data, but as far as the 2-year PFS is concerned, there seems to be no difference between whole brain radiation and autologous PBSCT. Now, as far as toxicity is concerned, in whole brain radiation, there was significantly more neuropsychiatric toxicity, as is well known and as is expected. And in autologous PBSCT, there was significantly more hematological toxicity, again, as is well known and as is expected. So there's a difference in toxicities. However, there is no difference in PFS as far as the IELSG consolidation data is concerned. Now, so these were the three options that we put in front of the patient and their family, that they can choose to go through autologous PBSCT. However, there was a significant amount of concern that since he had issues twice with standard matrix, that he may have more issues with autologous PBSCT. So they certainly were against it. And whole brain radiation therapy was put in front of him, and this was clearly discussed. However, this gentleman is a businessman who is actually a chairman of his company, of a IT company, and he in his life needs to make pretty rapid on the spot decisions. So he decided that he does not want any treatment that would potentially impair his cognitive function in the future. As I'm sure all of you are aware, whole brain radiation does affect cognitive function and neuropsychiatric testing to some degree, either a lesser degree or a higher degree, and all patients have to be counseled upon that. And then it is their decision whether they want to take that risk or not. And this patient very clearly made the decision that he does not want whole brain radiation. So his wife did not want autologous transplantation. Patient did not want whole brain radiation therapy. So as a compromise, we decided to merely follow him. So as of today, he's under observation only. It's been approximately 10 months since we treated him. By the grace of God, he has not had a recurrence, but we do have him under close observation and follow-up. If the tumor does recur, we can potentially consider high dose therapy salvage at that point in time. Typically, we would salvage him either with the same regimen or with high dose methotrexate if the disease free interval is more than 12 months. If the disease free interval is less than 12 months, we would use another non cross resistant high dose regimen. And if he responds to the salvage, then we can most definitely consider autologous peripheral blood transplantation, high dose chemotherapy, and auto PBSCT at that time. So as far as standard consolidation is concerned of primary CNS lymphoma after treatment with a high-dose methotrexate-based regimen, our choices are mostly between, as we just discussed, high-dose chemotherapy and autologous PBSCT. High-dose chemotherapy has improved significantly these days. We have several conditioning regimens available which are highly penetrant into the CNS. Many of you must have heard of BEAM, which is a kind of standard conditioning regimen used for a non-Hodgkin lymphoma. Beam is not the ideal conditioning regimen for primary CNS lymphoma because, again, as we discussed, like CHOP, the penetration of beam into the CNS is not adequate. So we typically use a combination of carmustine, thiotepa, and etoposide, or just carmustine and thiotepa without etoposide. And auto PBST is one consideration. Low dose whole brain RT doses between 24 to 36 grays given in 1.8 to 2 gray fractions is very much one standard of care in appropriate patients who are willing to risk the neuropsychiatric and neurological toxicities. High dose cytarabine with or without etoposide is again another very popular, very common, time tested consolidation if it has not already been used in combination during induction. We have newer agents as well, as we discussed previously. We have temozolomide, we have vincristine-based regimens, and so on and so forth. So this is a quick summary of some of the most popular regimens that were used. As you can see, most of the overall survivals are in the 30 to 40 month range. Seem to be better these days with modern supportive care than the older data. And based on phase 2 trials, autologous PBSCT seems to have a marginal advantage in event-free survival or progression-free survival. No clear data whether it significantly improves overall survival as yet. Now, what is the role of whole brain radiation in general for primary CNS lymphoma? Historically, as you know, radiation, the invention of radiation predated the invention of chemotherapy. And for many years in the past, primary CNS lymphoma and most of the tumors for that matter were treated with radiation alone when they could not be operated. So for many years, radiation alone has been one standard of care for primary CNS lymphoma. Even today, several protocols use whole brain radiation, and we all know that it's quite effective in primary CNS lymphoma just as it is in any other lymphoma. However, in the modern era, we know that radiation in general for the brain has inadequate local control. We already discussed this in the initial slides. Primary CNS lymphoma, by definition, is an infiltrative whole brain disease. Even if it looks localized on an MRI, in actuality, it is not. Almost always on either histopathology or autopsy, we find that it is infiltrated through into the parenchyma, quite often even into the contralateral brain and into the leptomeninges, even if it is not clinically evident. So, radiation alone is unlikely to be, does not give adequate local control, and it's quite common to see recurrences even within the irradiated fields. There is almost always CSF dissemination at some point or the other if you use whole brain radiation alone. And there's a fair amount of neurotoxicity, and the relationship between neurotoxicity and the radiation dose is linear. The more the radiation dose, the more sterilization you achieve, but at the same time, more neuropsychiatric toxicity that you get. So typically, doses of 36 to 40 gray have been used in the past, and they do demonstrate a high response rate, but very short overall survival, and it is doubtful whether they have any overall survival advantage at all. The age also is another very important factor. Lot of us intuitively say, especially medical oncologists, elderly, poor performance status, just give him radiation. Why subject him to the systemic toxicity of chemotherapy, which is a valid argument and which may be suitable for many patients. So that's certainly fine. However, you do need to realize that age influences toxicity, neurotoxicity as well. Elderly are much more vulnerable to neurotoxicity from radiation than the young, dose for dose. Quite often, patients over the age of 70, if they get radiation alone for primary CNS lymphoma, neurotoxicity is such that very frequently they require assisted care. They lose the capability of independent activities of daily living. So this is something that you have to keep very clearly in mind and counsel patients and discuss with the radiation oncologist thoroughly on a case-by-case basis. The argument that just because somebody is elderly, let us avoid systemic chemotherapy is not valid. So the decision to give radiation either as a sole modality or as consolidation has to be carefully considered with these paradigms in mind. Now, let me go back to the GPSG1 trial, which we discussed briefly a few slides ago. The German primary CNS lymphoma study group 1 trial is the largest phase 3 randomized control trial conducted to date in primary CNS lymphoma. It is more than 550 patients, and this was conducted in Germany, obviously, and in Switzerland. And all patients on this trial were induced with either high-dose methotrexate alone or high-dose methotrexate plus ifosfamide for a total of 6 cycles. And after induction, they were then randomized to consolidation. And in consolidation, if they had a complete response, they were randomized between whole brain radiation versus observation. If they did not have a complete response, they were randomized between whole brain radiation and high dose RSE. Now, the net upshot of the trial is, as far as overall survival is concerned, the median overall survival with chemotherapy and radiation is 32 months. The median survival of chemotherapy alone without radiation consolidation is 37 months. This was not statistically different. So one of the largest randomized trials in primary CNS lymphoma suggests that the addition of whole brain radiation as consolidation may not improve the overall survival at all, provided the patient got enough high dose methotrexate based chemotherapy as induction. Now, in this trial, the progression-free survival was marginally but significantly increased with the whole brain radiation. This is consistent with the data that we see with localized radiation anywhere in lymphoma, anywhere else in the body. Radiation does improve the PFS, but does not necessarily improve the overall survival. And radiation came at a substantial toxicity in this study as well. There was a 50% grade 3 or grade 4 neurotoxicity with these doses used. Notice that the doses are relatively higher. They used a consolidation dose of 45 gray. In this age, we typically, if you're going to consolidate, we typically recommend a dose around 36 to 40 gray, which has a much lesser toxicity. But on this trial, which used a slightly higher dose of radiation in consolidation, you had a 50% grade 3 or grade 4 neurotoxicity. Many patients were unable to take care of themselves, did not have independent activities of daily living after radiation was completed in the long run. So this is something you have to keep in mind when you recommend whole brain radiation as a consolidative strategy after adequate induction chemotherapy. So I finished my talk there. I'm open to questions. I think we have a couple already. Dr. Ravikiran suggests that Dr. Meenakshi suggests that RT is essential. I think we have addressed that question. RT is not essential. It depends upon the specific regimen that you use. RT definitely has a role to play. There is no question that radiation therapy improves the progression-free survival, even if it does not improve the overall survival. However, it comes with a significant amount of radiation neurotoxicity, and you have to consider that in an individual patient by patient basis. But in modern regimens, there are regimens that avoid radiation therapy completely in consolidation, as we just discussed. So no, radiation therapy is not essential. Dr. Ravikiran says partial brain RT may be less toxic. You're absolutely right. As we just discussed again, there is a linear relationship between the dose of radiation, the fields of the radiation, the age of the patient, and the toxicity. However, partial radiation therapy will also will result in poorer control of the disease. Dr. Meenakshi says, how do we diagnose without a brain biopsy and when is surgery recommended? Now, we discussed that in the very first slides. The diagnosis without a brain biopsy is done on clinical basis and radiological basis. clinical basis, typically middle-aged people, typically a male. This can happen at any age, in any sex, in anywhere. However, the typical patient is a middle-aged patient, a male who presents with rapidly progressive neurological deficits, who on imaging, especially on an MRI, has in an immunocompetent patient an isolated lesion which is infiltrative, which is periventricular, which is homogeneously enhancing vividly with gadolinium, and which is hypo-intense on T1 weighted images. This is the classic situation of a primary CNS lymphoma without evidence of disease elsewhere. So this is how we clinically diagnose a primary CNS lymphoma. Majority of biopsies in this situation turn out to be primary CNS lymphoma. However, rates, treatment for primary CNS lymphoma based on a clinical diagnosis only is not recommended at all. High dose methotrexate, high dose cytarabine, whole brain radiation are therapies which are highly toxic and have to be done only under very specific controlled circumstances. All of you know, I don't have to teach you how to give high dose methotrexate. I'm sure you know quite well, and they cannot be given without a established histopathological diagnosis, period. So we do not suggest attempting these toxic therapies without a biopsy. Now, the question Dr. Meenakshi raises is a very important question, and we have faced that in several times in our clinical practice. You have a very sick patient who is interested in some kind of therapy, and clinically, as we discussed, on a clinical basis and on a radiological basis, this looks like classic primary CNS lymphoma. However, a biopsy is not recommended by the neurosurgeon for safety sakes. For whatever reason, we are unable to do a brain biopsy. What do you do under those circumstances? This is my open question to you. Does anybody have any answer? Any suggestions? In other words, the question is, in a clinical situation where you are almost sure clinically there's a primary CNS lymphoma, but the patient is too sick, too weak, or has too many comorbidities, and or the lesion is so situated that you cannot do a biopsy. The center does not everybody has a stereotactic biopsy available, not everybody has an experienced neurosurgeon available. Whatever be the reason, you're unable to perform a biopsy. How do we treat? What do we do with such kind of patient? We have faced this situation in the past. So typically what we do in a situation like that is give high dose steroids. So high dose steroids are given, and as you know, if it is indeed a primary CNS lymphoma with or without edema, with or without mass effect, they are very, very responsive in the short run to high dose steroids. And that can be a very, very effective way of controlling primary CNS lymphoma in the short run, even without a biopsy. Now, we had a couple of cases where we did this. We gave high dose steroids, and the lesion completely disappeared, and the patient just sat up and became well. Now, that's a sort of dilemmatic situation where you were unable to do a biopsy for whatever clinical reason, and you did try, you're convinced that it is a PCNSL, and you gave them high dose steroids, and the patient improved dramatically, and the lesion completely disappeared. Then what we do in that circumstance is we taper off the steroids, because please remember that steroids do not solve the problem in the long run. Steroids have their own toxicity in the long run, as you very well know, and the lymphomas typically break through, typically develop rapid resistance when you give steroids alone. So steroids are not a long-term solution, they are a short-term solution. You give high dose steroids, if the patient improves quite well and the lesion disappears completely radiologically, the only thing to do is observe them. Just observe them, repeat the MRI periodically every 3 months for at least 2 years. If the lesion never comes back, well and good, everybody is happy. If the lesion does come back, then you do a biopsy at that point in time and refer him to a center where there is a stereotactic biopsy. I think this is a very important thing. Many of us have a tendency to try and keep our patients with our own institution, which is perfectly fine for the most part. But in certain situations where you know that there are definite facilities where there is a facility with a stereotactic biopsy and an experienced neurosurgeon outside, I think in the best interest of the patient, you should be referring the patient to such a center so that he can get a stereotactic biopsy and come back with a proper diagnosis. In those patients who do respond to steroids and their performance status improves, their clinical situation improves, but they do have a residual lesion, then you can try and attempt a biopsy at that point in time. So, in answer to Dr. Meenakshi's question, we do not recommend, you can make a clinical diagnosis without a brain biopsy. In such a case, you are justified in treating with steroids, high dose steroids, if you do not have a proper brain biopsy, and then make a decision based upon the response. When is surgery recommended? Surgery, this also we addressed in our initial sites. Surgery is typically recommended when there is a large mass, large lesion, it is peripheral, and if there is a substantial mass effect going on, and you really don't have the luxury of waiting, otherwise you are afraid of herniation or significant neurological deficit. So in those cases, taking them for surgery and doing maximal debulking to the safest extent possible is quite reasonable. Now, the other question we have is, Dr. Sumit says, if a patient develops methotrexate-induced leukoencephalopathy, say after the first cycle, how do we treat him further? Good question. Methotrexate is not a fun drug, as you all know. It can cause many different problems. One of them, quite common, is leukoencephalopathy. Now, in the vast majority of cases, leukoencephalopathy is reversible. So if they have grade 1, grade 2 leukoencephalopathy, and that is completely reverses, you can proceed with further high dose methotrexate and complete the recommended number of induction cycles as recommended. However, if they have grade 3, grade 4 leukoencephalopathy, you cannot use high dose methotrexate again. You can switch to the alternate non-cross resistant drugs such as high dose cytarabine. That is a typical salvage that we use when we cannot use high dose methotrexate levels. I'm sorry, high dose methotrexate. The other question that we have is Dr. Meenakshi, supposing patient is in remission, how do we monitor for relapse? Typically, we do an MRI of the brain every 3 months for a minimum of 2 years, apart from a systemic examination and the usual blood tests, including LDH. And Dr. Sumit has the same question. And Dr. Siddharthananda asked a good question. What about an ibrutinib-based regimen? Excellent question. Recent data suggests that ibrutinib, as you all know, is a Bruton kinase inhibitor, has substantial activity in primary CNS lymphoma, just as it has substantial activity in certain cases of non-Hodgkin lymphoma, especially the BCLS6 overexpressing tumors. Now, most of PCNS CL can respond well to the ibrutinib. At this point in time, the data supports the use of ibrutinib in the salvage setting. So, ibrutinib is now not a part of standard initial induction or consolidation. Initial induction consolidation still remains high-dose methotrexate with a non-cross resistant chemotherapy with or without rituximab, with or without radiation. Ibrutinib is now a very is a drug worth considering in relapsed primary CNS lymphoma, especially those who are not eligible for other high-dose salvage strategies. So Dr. Siddharthananda says never treat any patient with biopsy. I think we already talked about that. Dr. Ravikiran says HIV, EBV radiology. We discussed that in our initial slides. Dr. Venkata Pradeep Babu says, if patient receives steroids before presenting to us, can we still go ahead with biopsy? What is the chance that we may get the tissue diagnosis of such patients instead of necrosis? Unfortunately, Dr. Pradeep, this is a common situation in this country. Typically, patients are referred to us from primary care, secondary care centers. By the time they come to us, with all good intentions, their doctors there have already started on steroids, stabilize the patient, sent to us, and we are faced with, we were held holding the baby and we really don't know what to do. You can't afford to stop the steroids, you can't afford to do a biopsy. In general, if you have a primary CNS lymphoma and you start them on steroids, the response is very dramatic and very immediate. Having said that, virtually nobody gets a complete response. And or rather, very few people get a complete response. The majority will take several days before they get a complete response. So, what I would suggest is get a proper, good MRI, review it with a radiologist, and then mark the areas where how much necrosis is there, how much enhancing tissue is there, and then discuss with the neurosurgeon and go ahead with it. If you have stereotactic biopsy available, if you have an experienced neurosurgeon who is using his fiducials properly and who is reviewing the MRI and is guiding his biopsy needle according to the MRI lesions in concert with a neuroradiologist, you are likely to get sufficient tissue, sufficient viable, adequate tissue within days of starting steroids. So yes, it's worth attempting based upon a good review of proper MRI images with a neuroradiologist and a neurosurgeon. Now, what about a situation where we do attempt a biopsy and we end up with necrotic material? In that case, your hands are tied. You will have to do either one of two things. Number one, either you'll have to discuss with the neurosurgeon and with the patient and go ahead with an open biopsy if it is safe. If an open biopsy is not safe, that in other words, if neurosurgery is not safe, neurosurgical biopsy is not safe, in that case, you will have to complete the course of steroids, taper them out slowly, and just monitor response, as we discussed a little earlier. And I completely agree with Dr. Siddharth Nanda, who made a comment that never treat any patient with a biopsy. Again, we all repeat, never treat anyone with high dose chemotherapy or even whole brain radiation without viable tissue and an established histopathological diagnosis. Sir, could you please provide us your email ID? Dr. Pranav asked that. Oh, certainly. I think the team can do that. Dr. Meenakshi, role of maintenance. Well, that's an interesting question. As of today, there is no known standard maintenance therapy for primary CNS lymphoma. Most of the protocols, actually all the established protocols, look at induction and consolidation, but there is no real maintenance. Having said that, there are two trials that I think we should note. One of them is a phase 1 trial that looks at the use of high dose methotrexate as a single agent given as induction. People who have a good response but not complete response continued on to get high dose methotrexate once a month for 1 year as maintenance, and they seem to do quite well. So that is something that you could consider in certain specific cases. People who are not eligible for any other chemotherapy, people who had some kind of a response to high dose methotrexate based induction therapy, you can look at continuing high dose methotrexate once a month for a minimum of 1 year as maintenance therapy, as long as there is no progression. The other trial is a trial of is again a phase 2 trial which looked at the role of temozolomide in maintenance. So on this trial, you had induction with RMPV, that is rituximab, high dose methotrexate, procarbazine and I'm sorry, temozolomide and vincristine, and those who had a response were consolidated with whole brain radiation. After consolidation with whole brain radiation, they went on to get temozolomide as maintenance therapy indefinitely until progression. So that has been tried. However, having said that, this is phase 1, phase 2 data only. There may be a role for maintenance therapy, especially in those patients who were unable to achieve adequate doses of high dose methotrexate, or in those patients who do not have, who were not able to get adequate dose of high dose methotrexate, and in those patients who achieved only a partial response even after consolidation, and in those patients who are elderly and are unlikely to tolerate more significant therapies, I think it's reasonable to consider some kind of a maintenance therapy, such as with temozolomide alone or temozolomide with rituximab, which is another published trial in the elderly. So maintenance therapy in primary CNS lymphoma, no established role, but you can consider it in certain specific cases. Dr. Sumit, any role of newer anti-CD20 like obinutuzumab? To my knowledge, there is no data looking at obinutuzumab in primary CNS lymphoma. Unlikely that will prove to be a much benefit because that also is a large molecule and doesn't cross the blood-brain barrier that well. So any other questions? Dr. Siddharth Nanda, thanks for your excellent and very lucid presentation. Thank you, Dr. Nanda. Most of you are very patient with me. I would prefer to actually see you and interact with all of you face to face, but I guess we are all technologically challenged, and unfortunately, that was not possible. Still, I hope you had some benefit from this talk, and it was a pleasure interacting with all of you, even if it is on the text messaging. And if there's no other questions, I think we'll wind up at this point in time. Shall we? You want me to say my email ID now? My email ID is, um, well, I'm going to give you my personal email ID, so don't send me any personal patient information. It's HALARASRI, Halarusri at yahoo.com. I can probably write it here. Can I write it here? No. So I repeat once again, it's HALARUSRI at yahoo.com. Thank you all. Oh, there's just one question. Dr. Meenakshi is asking about MRS choline uptake. Yes, it's high. You'll have a very tall choline peak if you do a MR spectroscopy. I don't think I missed any other questions. Okay. Thank you all. Bye.